patient who had liver transplant. The patient's status was liver transplant and had kind of like post just screening MR. And the patient had this lesion that was seen after liver transplant. There's the T2. I mean, excuse me, post-con. This is the T2. And then diffusion is here. Oh, no, that's not the diffusion. No. Where's my diffusion? Oh, here it is. Any thoughts? Here's a diffusion. Right there. And then.
Wait, was there washout? Like, is there a later phase?
Yes. Let me give you the delayed. Here's the 5 minutes.
So it's not really washing out. Because if you think like.
So it came with the transplant. Sorry, go ahead.
It came with the transplant.
Yeah.
How do you know that?
Well, the patient's status was transplant.
Right, but it could have grown after they were transplanted, like PTLD or something like that, right?
That's a good point. We don't have any imaging of the transplant itself. So you're right.
That's a question I have actually that people have asked me before, like how much imaging do they do of livers before they transplant them?
Not much, right? I mean, they don't do any imaging, do they?
You must at least do an ultrasound.
I don't know. Well, it doesn't come with it. We don't get the donor, but it would be on, I guess, different under. Anyways.
Because I would think that they would have at least done an ultrasound and they would not have transplanted if this lesion was there before.
Well, obviously imaging was not done because this was transplanted. And this was a first post-op imaging, just surveillance imaging. Any guesses? This was a surprise diagnosis, so that's why I'm sharing this.
I guess the delay makes me think of FNH just because it's so iso, but it would be like a very atypical FNH. Given how T2 bright it is.
Right. Yeah. I thought the T2 was too bright for an FNH.
But they can be T2 bright.
Yes. And this was an FNH.
Cool.
Yeah. I think that would just be in the diff though. Not a slam dunk case. But it was a surprising pathology.
And actually, maybe then if they did a pre-transplant ultrasound, it would have just blended in because those are harder to see on ultrasound too.
That's true.
Because I'm pretty sure they do some imaging on the liver. Because I know they do all sorts of other tests, like they'll make sure you have mammograms and your, pap smear. And so if they're going to transplant the liver, I think they'll at least do an ultrasound of the liver.
Okay. So this next case is.
So Aarti, sorry to interrupt, but comment on that case. We have a case of liver lesions post-transplant. I'll try to find that case, probably won't be able to find today. Maybe I can show it next time. And on imaging, it almost looked like there were FNHs in the liver. So we called that and we did Eovist also. There was some retention and we weren't sure again if it's an adenoma versus FNH. And so they biopsied those lesions and they turned out to be adenomas. There were like, I think multiple lesions, not one. So we were looking at some articles and so FNHs in a transplant liver are known. I mean, there are some case reports that you'll find or maybe some studies. And it's because of the perfusion changes in the liver that can happen after transplant. But I couldn't find a good reference for adenomas in the liver post-transplant. But we do have a case which is a biopsy-proven adenoma after transplant.
Yeah, so you're saying that they grow, or like they can start proliferate and or grow
after, yeah, just like in a native liver.
Cool.
Awesome. Okay. I'm So this is a CT urogram in a polycystic kidney. And in this case, the calyx, the left upper pole calyx is dilated. And then you kind of go down, and you see that it's kind of squished here by the cyst, which has mass effect on the infundibulum, causing the calyectasis. And I came to learn that there's a name for that. And it's called Fraley syndrome. It's a condition where the superior infundibulum of the upper calyx is obstructed by something, usually a crossing artery, like a segmental renal artery. And then it causes dilatation of the calyx. It can lead to clinical symptoms like hematuria, sometimes flank pain, ipsilateral flank pain. So yeah, this is an example of Fraley syndrome.
Very cool. It seems like you could aspirate that cyst and alleviate this syndrome.
Yes.
And or sclerosis too.
That's fair. Yeah. I don't think we did it, but I don't know that it was causing any problems. I think it was maybe
yeah, maybe it's only
called
the syndrome when it's like symptomatic.
Yeah, it's possible. Very possible. Okay, this next case is a Aunt Minnie. One second, loading.
Neurofibromatosis?
Yes, yeah. So there's, you have plexiform neurofibromas and mesenteric neurofibromatosis. The plexiform mesenteric neurofibromatosis that we see in the left upper quadrant. And that's pathognomonic for NF1, which this patient does have a history. And then you get, the patient also has neurofibromas along the bilateral vertebral bodies as well. And then they're like large and fusiform and tortuous masses that we see here. Apparently, intra-abdominal or retroperitoneal localization is very rare. But I feel like we've seen a handful during this case conference, so it can't be that rare. Unless we're a case conference of rare diseases.
I think they also have an increased risk of like duodenal adenomas and cancers and stuff. So some of those patients we have to look at the GI tract well.
Yes, yeah, they have increased risk of multiple other tumors because of their genetic predisposition. So I can pause there, or I can keep going. Any specific?
Why don't you keep going?
So we did an MR.
Sorry, I missed that on the recording. So it's post-liver transplant and leukocytosis. Okay.
Correct, yeah. So we got an MR and we got, there was a fluid collection on the ultrasound, so we got an MR subsequently. And here is the 20-minute post hepatobiliary phase. Oh, hold on, arrow sign.
So it looks like a bile leak.
Yeah,
Could you see if it was at the anastomosis or? Yeah, it actually looks like it's emanating from where the anastomosis would be.
Yeah, exactly. And then we got ERCP. Oh, what does that red thing mean? And the ERCP images show the leak at the anastomosis beautifully. Okay.
Nice. So do you think they just treated it with a stent?
Yeah, I think we just stented it. and then just decompress the system and let it heal.
Yeah. Thank you. Gitanjali, do you want to go?
Yeah. Okay, can you all see my screen?
Yes.
So 56-year-old female with this incidentally detected renal/perirenal mass. This is the axial haste. Coronal haste. Can show in and out of phase. So no obvious dropout. This is the pre-contrast T1, so not T1 bright. These are the post-contrast images. So arterial phase, portovenous phase, and delayed phase. So it's enhancing, but really not really characteristic either. It doesn't have any robust arterial enhancement. It doesn't have like very nice washout, some restriction. So what would be the differentials here that we, I don't know if I'm, as far as the images are concerned, probably not an really interesting case, but the path diagnosis was really interesting.
Because it's T2 hypo, I know you can get leiomyomas.
Yes, so that was the first differential that we considered, that probably a leiomyoma because it's rising from the surface and it's T2 dark.
Swachanda is also saying papillary RCC and lymphoma.
Yeah, the question is like, should we consider any of these renal masses? Like, is it purely capsular and perirenal mass, or is it arising from the renal parenchyma? That's what I was trying to look for really hard on this case. And I thought it looked pretty like either from the capsule, but I really didn't see, I don't know if there is like very subtle parenchymal involvement, but usually these masses which are predominantly growing into the perirenal space, they'll have like a tiny wedge at their base, but I didn't see that. So I wasn't sure, is it parenchymal or just capsular or perirenal?
Hard to say for sure not, right?
Yeah. So the path report on this turned out to be leiomyomatous variant of an AML. So I thought that was interesting. Yeah.
Sure.
So, I mean, then obviously I pulled up some review articles and it was really interesting to read about AML variants. Let me pull this up here. I don't know if you all can see this PDF, which talks about different morphologic variants of AML. So AML now has been classified as a PICOMA. PICOMAs are like spindle cell tumors which show two markers. They are markers positive for desmin, which is a muscle marker, and they have immunohistochemistry markers positive for melanocytes, which is HMB45. So they're classified as PICOMA. So you have the epithelioid variant, which can mimic RCC. These are all lipid poor AMLs, so they can mimic RCC. And this is the malignant variant. Then you have the oncocytoma-like variant. And this is what this turned out to be, the leiomyoma-like variant. And the other interesting thing was they're called capsulomas. So this actually looked like it was arising from the capsule. They say it's subcapsular location, but yeah, this one looked more extracapsular than, or perirenal. And then some other variants. So I think something where we can discuss the differentials for T2 hypointense lesions rising from the renal parenchyma or lesions in the perinephric space. The other differentials for perinephric space masses would be something like lymphoma, extramedullary myeloma can happen, and then histiocytic disorders like Erdheim-Chester, Rosai-Dorfman, but those are more infiltrative kind and not well circumscribed like this. So I thought that was the interesting thing.
This reminds me of a case that I recently had that was, it was more parenchymal and not capsular, but it had that T2 hypointensity, and then it did enhance less avidly than the renal capsular and RCC. And so I tried to apply that clear cell likelihood score, which has recently been actually written up pretty well in the recent radiology journal, and it came out indeterminate. So I'm wondering if this is the histology, because it was in a demographic that's less commonly for RCC.
Yeah. Oh, I didn't know about that score. I'll read it up.
Yeah, I'm betting if you applied that here, there you get into, after it's T2 hypo, you
Mhm.
get into trying to measure the degree of enhancement percentage relative to the renal cortical enhancement, and ours fell into the
Intermediate.
intermediate or moderate
Indeterminate.
category,
Okay.
which leads you to a kind of an indeterminate.
Gitanjali, was
think-
this one biopsied or resected?
I think biopsy. Yeah. Not resected yet.
Because yes, Steve, even your case, if it's in that intermediate or indeterminate category, it should be biopsied, which
Yeah,
I think
that's
you're trying to just prevent unnecessary resection. So
That's indeed what I recommended. I said recommend urologic referral for consideration of biopsy versus surveillance versus intervention. So I kind of ordered it in the way I thought was most appropriate.
yeah, we just talked about that the paper about the clear cell likelihood score, CCLS, in our journal club. And it's a little complex, but I've found that it's helpful when you have like an atypical lesion, like the one you're talking about.
It is. I mean, like many things that are more complex, it would lend itself to some sort of calculator or algorithm that's built into your reporting system. Someday we'll get there, maybe.
Yeah. And then actually I have a question, Gitanjali, when you're reading, why, I was just trying to look up like what the renal capsule is made of, because I was thinking like, okay, is there smooth muscle in the renal capsule? And I don't know, I'm finding like that there's like collagen and elastin, but do you know why they get leiomyomas there?
No, Aarti, I don't know about the path, but yeah, the most common differential for like a capsular mass is leiomyoma. That's all I know.
Okay. Anyone else have cases? I have one. Start sharing. Hold on, let me pause. Okay. So this is a younger patient, around 20 years old, who presented with this lesion. Make it a little bigger. Okay, so we can see that there's a low density mass on CT. It seems to be touching the pancreatic head. It has a septation. Any thoughts?
Doesn't
I can
have
also just,
doesn't have a clear organ of origin for sure, right?
yeah, I did not think so. I didn't think that this was a definite claw or that the kidney had a claw.
So then you're in a differential of cystic masses without an organ of origin, which is,
Yeah, so what's your differential?
well, lymphangiomas or duplication cysts or seromas or non-pancreatic or pancreatic pseudocysts, depending on if the patient has had pancreatitis.
Okay. And there was one more thing that we thought of, which is an MCN. So you can get mucinous lesions of the retroperitoneum or mesentery that are not necessarily from the pancreas. So anyway, we got an MRI. And this is what it looked like on MR. So this is the T2. You can see there's definitely a septation. There's this component over here.
It was hard to appreciate that.
Yeah, this is why an MR is much more,
CT, right?
yeah, this MR is much more helpful than the CT. So anytime you have a cystic lesion, I think an MR would be better. You can see on the pre, it's T1 hyperintense here with a filling defect down there. Post contrast, given the T1 hyperintensity, I'm just going to skip to the subtraction images. Most of it is not enhancing. That septation is enhancing. And there was some kind of like smudgy enhancement. What'd you say, Steve?
I didn't say anything, but somebody typed in sarcoma as a possibility.
Okay. So, and actually on this venous phase, again, we see this kind of smudgy enhancement down here. So given that it's seen on both the subtractions, it's not just this kind of like misregistration, we thought that there was that solid looking part on the T2 was likely.
Looks like it's got the potential to be a neoplasm then.
Right, exactly.
Yeah, I mean, it's got a thick rim around it.
Yes. I don't know why I'm hearing some feedback, but
I'd probably send somebody in to take it out.
okay, good. So they went, we said we can't exclude like a mucinous neoplasm with like a malignant degeneration.
I think you can also get cystic like paragangliomas, can't you?
Yeah, I've never seen them this cystic, but you can definitely get cystic schwannomas and paragangliomas. Yeah. And most paragangliomas have some cystic component, but usually they have a more solid component too. And the other possibility was, like you said, duplication cyst, and they can have malignant degeneration. So anyway, this was resected, and they actually had to resect part of the pancreatic head. They did not have to do a Whipple, but it was sticking to the pancreatic head, and it came back lymphangioma.
With no
So,
malignancy?
no malignancy.
Oh.
Or why it had that enhancing smudgy stuff.
No, but, and I would try to look, there basically was like a radiographics from the AARP. They had like over 100 abdominal lymphangiomas. Some of the points they made was that they're more commonly in the mesentery. Second most is in the retroperitoneum. I think this one was a retroperitoneal one, but you can also get them in the intestines, the kidneys. Aside from that solid part, I think we would have all kind of said like, yeah, maybe this could be a lymphangioma. They're not that uncommon. But they don't really mention in that paper about except for septal enhancement. But in Radiopedia, they actually say that there's a large variability, and some can even have like more solid components or solid components with cystic parts to it. So I don't know. I don't know what the takeaway is here. I think this is still like a surgical lesion. You'd have to resect it, but good for the patient. And just so you know, lymphangiomas can be variable. I'm thinking maybe this is just like they're filled usually with lymphocytes, and then they have these sort of fibrous septa. So I'm thinking maybe this is just kind of like reactive fibrous kind of tissue. But there was no malignancy.
I can share a case.
Okay.
This patient had symptoms of dysphagia. That's a good one. Is this a good one? No.
There's an epiphrenic diverticulum.
Yeah, isn't that cute? I had to show this.
Yeah. Wait, and they're aspirating too.
A little bit, yeah, right there.
That spasm or stricture adjacent the neck of that diverticulum?
I think it's spasm. Here, let me find a better one that shows you that it's a pretty wide open. There.
Oh, yeah, I like that better.
Yeah. I
Although
like the
supposedly
continuous.
they're like pulsion ticks from usually associated with a stricture, right? Because like it's pulsating against some kind of obstruction.
So yeah, they are supposed to be pulsion, diverticulum, but I guess apparently intraluminal pressure can also cause them to.
Wonder if the propensity to spasm in that location led to a tick formation.
It's possible.
Looks like it's a slight HH too.
Yes. I think the continuous swallows bring out the HH really well.
Yeah.
And then another case. This patient has liver lesions. We showed this, I think, recently, and this is a companion case. So here's your pre's, T2s. Where's my arterial? And then here is 18-minute delay. Hepatobiliary phase.
Nelly, do you have an earlier arterial than that?
Yeah.
That looks like a venous phase to me.
I think this is the earliest one I got.
Okay.
Sorry,
So
it's a
we're thinking
late
they're generally
arterial.
iso, but like non-retaining on the hepatobiliary.
Correct. And then diffusion is right here. Okay, any guesses?
There's a guess in
is
the chat.
Hepatobiliary face. What?
There was a guess in the chat.
Oh,
Of hemangioendothelioma.
that's a good guess. Yeah. This one turns
Those
out,
multifocal hemangioendotheliomas. I
and
kind
they
of
usually have a T2.
one big
sorry.
one.
They're usually, well, I think they're
Like-
talking about epithelioid hemangioendothelioma, which are usually multifocal, subcapsular. But Nelly, you were about to say something about the T2.
Yeah, like the rim, right? It's a little bit more thicker rim.
Yep.
For hemangio, there's subcapsular. They can cause like retraction. The capsule looks fine here.
So Chanda is also saying serous breast cancer Mets, and I was also thinking Mets or lymphoma, I guess.
Good thought. Good thought. This is hepatic angiosarcomas.
Wow.
Tissue proven.
That's reminiscent of a recent case
Yeah.
here, right?
Right. Right. I still find them kind of hard. Not kind of. They are hard.
I
Yeah.
feel like a true arterial phase would be helpful here, because if they looked more, like the one that Victoria recently showed, it kind of had like a little mimic of a hemangioma, kind of
Kind of
like
more
splotchy arterial.
right.
Yeah, I
I-
mean, this has to be biopsied regardless.
Yep.
Yeah.
Exactly. That's exactly right.
Okay, Christine has a case.
This is a case recently where this 35-year-old guy has obviously this very large mass in the left hepatic lobe, and then maybe some smaller ones as well in the liver. And on post-contrast imaging, we do see that there is peripheral arterial enhancement, which kind of like fills in over time. And it kind of fills in, but I don't know. We don't have tissue for this yet. And I wanted to see what everybody feels about this lesion. I mean, I guess it could just be a giant cavernous hemangioma, but would you be comfortable just saying that that's what it is? Or would you throw in some other differentials too, like angiosarcoma or anything like that?
I was thinking giant hemangioma, but it's always helpful to have, some prior imaging to feel more confident.
I definitely think it's a hemangioma.
Okay.
And the other interesting thing is, like, next to it, do you see all those little guys?
Mm-hmm.
You can get like hemangiomatosis when you have all these like little ones next to them. And I think that's what those are too.
Oh, okay. Yeah,
Which
because
doesn't mean they're not going to resect it, because sometimes if it's stretching the capsule, it can cause symptoms, especially when it's giant like this. But that enhancement pattern and that T2 brightness to me really looks like a hemangioma.
Okay. Yeah, because the T2 is pretty like homogeneous other than some septations, right? And then, yeah, and it looks like the enhancement is following blood pool for the most part. Okay. Thank you.
Cool. Let us know if they do resect it.
Yes.
I have more cases if we want, or we can stop.
Yeah, go.
Okay. Share screen. This patient has been on active surveillance. The original abnormality was imaged, 2 years prior, and there was a lesion here in the apex. And that had been followed subsequently for several years. This is the T2 equivalent at that time. This little apical lesion on the left. And then we got a subsequent MR on active surveillance It was like low risk disease. So, and a year goes by and the patient gets another one, and there's that apical lesion that we see again. Here's a T2. And then patient gets a, like there's no significant change in the PSA, whatnot. The patient remains on active surveillance, and then gets a.
Be a little nervy on active surveillance here, because the glandular margin at the apex is kind of a tough one to clear if they're going to go after it surgically, especially.
Right. Yeah, that's right. Okay. So then this is the third MR, 3 years into active surveillance. So we see that apical lesion again. But this time the PSA had gotten significantly worse. There's worrisome clinical findings on clinically. So then the patient goes to the OR for a radical prostatectomy, and the pathology is surprising. There was a Gleason 7 lesion in the left apex. And the surprising part is what they found elsewhere that we didn't really see. So this is the original 3 years prior, 2 years prior, and then the most recent one. So the surprising pathology was a Gleason 9 tumor that was invading the bladder neck in the transition zone.
Nelly, what's all that stuff on the, like the right side of the transition zone there? It didn't have any restricted diffusion?
No. So this
Yeah.
this
It
thing
does
here.
look like kind of like the semi-lunar tumors that like to live in that along the anterior fibromuscular stroma. Some people call it anterior fibromuscular stroma cancer, but the stroma itself can't be the origin of it. It's just a pattern that grows there.
Here's a DWI. Aarti, I think you asked for DWI. Here's a DWI.
Yeah. So in retrospect, you still wouldn't have.
So I think compared to the apical lesion, which is obviously abnormal, right? That transition zone lesion, the only change, like looking back, I can see a change in the T2 signal, and now I've kind of I love the DWI, but now T2 has become a closer friend.
I mean, T2's always been the preferred
Yep,
method of analyzing
that's
the
right.
TT.
Yep, exactly.
Because the DWI and especially forget the contrast enhance, very unreliable. But this is a pattern of growth that you see, that one that's along the anterior fibromuscular stroma, and if you set up all the comparisons, yeah, there's something growing there.
Yeah, but I think it's very easy to walk over.
Oh yeah, it's sad that it's 9 and yet
Mm-hmm.
not showing us more on the diffusion.
Yep. And actually, there's been several cases where the diffusion was not helpful at all. Yeah, and it was all T2. And you had to be very careful. And so now I kind of like comb through the capsule because the minute you start to get blurring, and that smudgy charcoal appearance, it just has to raise an alarm. But it's very hard. I mean, had it not been for the PSA climbing, I don't know that MR would have been helpful. Or I don't know, maybe it would have been. I don't know. Very humbling. Anyways, that's my case.
Nelly, just a question about the bulging border there. Was there an extracapsular extension or?
There was bladder neck invasion, and it was intraductal carcinoma was present, cribriform present. Where is a capsule? No capsular extension.
So the anterior fibromuscular stroma is like a glandular margin capsule equivalent, and you got to go all the way through it for it to be extraglandular spread. Kind of reminds me of like the bowel wall.
So it's interesting. So you're saying it's kind of tougher, and maybe that's why it went down into it went more down and then into the bladder neck. because it wasn't able to get through that stroma.
Yeah, I mean, it probably does serve to a degree as a barrier, kind of like your, the, rectovaginal or rectoprostatic fascia.
I reviewed, pathology proven bladder neck invasion cases, and I gotta tell you, it's really hard to pick that up. And our urologists are wanting to know that, and I don't know. I think that's a limitation for us with imaging.
They're wanting to know which.
Bladder neck invasion.
I mean, that's a tough one, especially if you have a cancer that's involving the so-called median lobe, where it's like all that fungating tissue that looks like a tumor anyway. And then if you get a cancer arising in there, I don't know how you're going to clear the bladder neck. Honestly, you just have to say possible bladder neck involvement, maybe.
Nelly, in this case, did they resect the bladder, or it was just like the margin was?
The margin. So this was just a routine prostatectomy. They weren't expecting the transition zone lesion on path.
And do you know if they have to now go back and resect the bladder, or?
So the way our GU pathologists, the base of the prostate, I guess, contain parts of the bladder neck. And so then they do like, so they take that slice, that base, the super cranial most margin, and then they slice it even further, like a bread slice. And so then they like get really close margins of the bladder neck. And I guess routinely the way they've done in the past, you would never have called it, but because they do these extra additional pathology slices, they're now picking up all these bladder neck invasions.
So what was the final margin status? Was it considered a positive margin or not?
Let me see. I have the path report here. Okay, so Gleason 9, invasion into the bladder neck. The bladder neck invasion was present. Extracapsular extension was not identified. No SVI, no lymphovascular invasion. Oh, margins were free of tumor.
So they got
Negative
it all.
lymph nodes.
So the bladder margin presumably was negative then. And so what bladder neck invasion was there, they had resected around it.
So it was a PT3A N0. I thought bladder neck made it T4. Okay, all right, maybe. I guess not.
Yeah, I was thinking local T4.
Maybe it's like you're saying it's kind of inseparable. So
Yeah.
it's like considered part of the prostatomas. Cool. Anyone else have
going to
pieces?
irradiate, probably not. If they had a negative margin, they probably don't feel the need to irradiate, just monitor the PSA.
Yeah, that's the plan. Because the PSA is undetectable.
Right.
I mean, the patient has a very high risk of recurrent disease.
Right.
So they'll probably just follow the PSA, and if there is climb, then get a PSMA.
Awesome. Anyone else? Okay, have a good week. Bye.
Bye, everyone.